Hello, everybody. Welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Wesley Badger, who is a general surgeon at Monument in Spearfish. Welcome to the show, Dr. Badger. Glad to have you here.
Yeah, thanks for having me.
Now, you're a transplant, right?
I am. I am. Originally, grew up just north of Louisville, Kentucky, in southern Indiana, kind of small town there.
You don't have a Kentucky accent, though. What happened to that?
I've been gone long enough.
Really?
I think I never really had much of one, but it pretty much got washed out in Wisconsin.
Yeah, of course. I suppose a Kentucky accent, that Wisconsin accent would balance it out.
They kind of balance it out, yeah.
So you got just a normal English accent. Are you growing up around Louisville? Are you into whiskey at all?
It's like a great shame that I don't enjoy bourbon because every time we go home, there's like a bourbon trail. There's all these things. I don't really drink that much. I don't like bourbon.
I get it. Yeah,
I've tried.
Sure. Well, you're from the land. I mean, if you can't like it from the land that it's made the best,
right,
then it's probably just not your deal.
Yeah.
I would suppose.
If you want some, we always go through the airport. We can stop and.
Well, I'll be texting you for sure next time you're flying, especially when you get down there. So, do you have a family background in medicine as all, or how did you
Absolutely not.
Really?
No, my mom's a first grade teacher. My dad worked in a power plant. He had they have a hobby farm that I grew up on. Doing like corn, soybeans, board horses, but. I was always interested in science. Had a brother that's a nurse, so maybe a little bit.
Oh wow!
And just my undergrad was in biochemistry, and so I wasn't quite sure if I was going to go into medicine or if I was going to go into into chemistry and do synthetic organic chemistry. But I really enjoyed medicine, and I really enjoyed kind of the interaction that you have with people in addition to the science behind it, and that kind of swayed me to end up going to medical school.
Well, especially getting into the field of, surgery, general surgery. Yeah. Can you explain what that term means a little bit? I've said it quite a bit, and I'd like you to tell me.
The best definition that I ever heard for general surgery was from a guy in Roanoke, Virginia, at Carilion Clinic, and he said that general surgery is the surgery of the skin and its contents. Right? So
that's great.
So all these kind of general surgery was kind of the original surgery, right? All these subspecialties branched off as medicine's become, increasingly specialized and complex. But general surgery really is kind of this broad-based practice of these, disparate things that, just widely varying surgery. And so that's one of the things that attracted me to it, right? Surgeons have somewhat of a short attention span. And so
you're not the first one to say that.
Yeah, though. Right. And so this huge variety of practice is just a fascinating thing to do. And every day is, not something new, but it's always something a little bit different.
Right.
And, the other is, I think you get to apply what you learned every day. And when you train in residency, you don't learn how to do everything, but you learn how to think through everything and how to, apply that to a new problem that you are faced with.
Right. So we talked a little bit about this before we got on the podcast. I asked you what your favorite type of surgery is. And it's kind of what we want to talk about a little on this one right now.
Yeah.
And you said it was...
Yeah, so I really enjoy endocrine surgery, which is kind of specifically, thyroid and parathyroid surgery.
So what does the endocrine mean?
Yeah, so endocrine is just surgery on the endocrine system.
Okay.
So thyroid, parathyroid, adrenal, pancreas. This is kind of like the control system, hormonal control system of the body. And endocrine surgery is this fascinating intersection of surgery and medicine, right? So, for example, like parathyroid surgery, people come in and they have hypercalcemia, some lab abnormality, and you can do this extensive medical workup, but ultimately that results in surgery, right? And this surgery is not, it's almost more art, quite frankly, than surgery, right? Because it's always a little bit different. Every parathyroid's a snowflake.
Now, what you keep saying parathyroid.
Yeah.
What is the difference between that and
so
thyroid?
The thyroid's like a butterfly-shaped organ that drapes over the central neck. That produces thyroid hormone that is kind of like the master control for metabolic function within the body. The parathyroid is kind of like its little friend that lives behind it. So on average, people have 4 parathyroids, and they're about the size of a couple grains of rice put together. And they just live on the back of the thyroid. They're not like stuck to it, just kind of loosely associated. And they control calcium metabolism in the body. So they produce this thing called parathyroid hormone. And calcium is like this signaling molecule in your body, and it exists within a really narrow range. And if your calcium is too low or too high, you very much know it. People don't feel well. So if their calcium is high for some reason, like a parathyroid problem, they have the classic medical mnemonic is bones, moans, stones, and groans. So they have bone and joint pain. They can have muscle cramps, they have belly pain, they have fatigue or brain fog or those kinds of things.
And that comes from the calcium.
Yeah, just because calcium's high in your blood and it has these wide-ranging effects in your body, and you just don't feel good.
Right.
Elevated calcium can also put you at risk for kidney stones, and elevated PTH and hyperparathyroidism can cause bone loss or osteoporosis. So those are real problems. And people come to me, particularly from endocrinology, with there's kind of 2 types of hyperparathyroidism, and one I don't see anymore because people get their labs drawn so frequently, and those people come in symptomatic. And it's very uncommon that I see people that have like really solid symptoms from this anymore because their calcium has to get so high that they have a problem and they go in. We just check labs so frequently that we find it before it's really symptomatic, and we still frequently operate on those people to prevent these troubles from happening in the future.
Okay. So what are kind of the key indicators then that surgery is the best option for something like this?
Yeah. So there's really not a lot of medical options for this, right? This is a primarily surgical disease.
It is. Okay.
And there's kind of 2 pathways for this, right? One is the symptomatic, and that's kind of what we said. These people come in with bones, moans, stones, and groans. And those people automatically qualify for surgery because they are symptomatic from their hypercalcemia. The other pathway is this kind of asymptomatic primary hyperparathyroidism. And those people kind of have to meet a certain criteria because, just because your calcium's a little high or PTH is a little high doesn't mean you want to accept the risk of surgery. We have to know that you got a real problem before you do it. And so we have pretty specific guidelines about what those labs should look like before we start to talk about actually doing surgery for people.
What are what are the different types of surgeries for this? What happens?
Yeah. So there's kind of some work to get there, right? So we make this diagnosis with labs. We decide that based on those labs that somebody needs surgery. And then that's kind of where the art of parathyroid surgery starts to come in. And so one of the big things in parathyroid world is localization. And so if you imagine that you're hunting in the neck for something that when it's big is about 1 centimeter in size, it's really helpful to have a good imaging study to tell you where to go. And there's a couple different studies that we do to try to figure out which one of the 4 glands it is, where it's located, and how are we going to get it.
And again, you say these are about the size of a grain of rice?
When they're normal, they're about the size of a couple grains of rice.
Okay. God, that's still tiny.
When they're big, they're about 1 centimeter, like half an inch in size.
All right.
I've had them up to like 5, which is like, championship bass, like giant parathyroid that you want to take pictures of because it's so big.
Boy.
But when they're small, they're still pretty subtle, and so knowing where you're going is very helpful. And so we can do CT or nuclear imaging studies or ultrasound to figure out which one of these glands that we're looking for. Then in the operating room, we get into the neck. We kind of push the thyroid out of the way where we think the parathyroid is going to be. And then there's a couple ways to do it. We commonly do what's called a minimally invasive parathyroidectomy.
Where in the neck is this?
Yeah, so usually...
if people listening can kind of feel like where is it?
So if you feel your sternal notch, about 2 finger breadths above that is where we typically make an incision.
Okay.
Like a 4 centimeter incision or so. And then the parathyroids, when they form embryologically, they form at the base of the tongue, and then they migrate down the neck. Yeah, it's kind of fascinating.
Boy, no kidding.
And so that's why they have such a variable course, so they can live anywhere.
They generally get in that area is what you're talking. Okay.
Yeah, so most commonly, they're located within like 1 centimeter of the intersection of their current laryngeal nerve and the inferior thyroid artery. So there's some good landmarks about where you think it's going to be, but you kind of you're looking for it. So we push that little thyroid out of the way, and we find that adenoma where we think it's going to be. And that's kind of where minimally invasive comes in. So we just go to that one spot. If we find it, we pluck it out, and we can check labs while we're in the operating room. And so parathyroid hormone has a very short half-life. So at about 5 minutes or so, half of it in your blood is gone. So if your PTH is 100 and we pluck this little guy out, in 5 minutes it should be about 50. And then at another 5 minutes it should be 25. And so we have national criteria that we know when we've successfully taken out the right adenoma, because about 5% of the time there can be a second gland that we have to go look for. Now, this is where things get tricky is, if you go to that spot where your imaging says it is and it's not there, or if it looks normal, then we do a 4-gland exploration and we go find all the other 4. And that starts to, require some patience.
Well, all I imagine are these video game apps where you're looking for these, just you're hunting. I mean, you're out hunting for these things.
Yep.
Being that small.
Yeah, and that's the art of thyroid surgery,
there we
right?
go.
So you have all this science that got you there, right? All these labs, all this imaging that got you there. But then the true art is you're just, what you're looking for, and you're looking at all the hiding spots that you think of, and you just patiently look.
What else is around there that gets in the way?
Yeah. So the thyroid's there. Typically, that we mobilize that pretty easily without changing blood supply or affecting the thyroid.
And how big did you say it is about the thyroid?
It's about 5 centimeters cranium caudal. So yes.
But where you can see that, you can move it.
Yeah, we just kind of push it out of the way. Carotid artery, IJ, internal jugular vein live around there.
Oh, that's all in that area.
Yeah, thyroid overlies trachea, esophagus. The most important thing that we look for in that area is the recurrent laryngeal nerve. And so on either side of the trachea, in this tracheoesophageal groove, there's a nerve that controls the voice. And so we have a special monitor in surgery that lets us find and protect that nerve. And that's another, a big risk of this surgery is injury to that nerve. And that can give you a hoarse voice. So obviously that's a really bad thing that you don't want. And so that's another reason that we take our time and are very careful with that nerve. There's a fascinating history behind thyroid surgery and thyroid nerves. So the recurrent nerve is what everybody always thinks about, right? Because it's a big thing. If you have a recurrent nerve injury, people wake up and they know it, and you know it, and it's awful. But there's another nerve that's called the EBSLN, or the external branch of the superior laryngeal nerve, and it kind of controls the tone and timbre of the voice. And it's now called the nerve of Galli-Curci. So there's
who's Galli-Curci?
Yeah, there was a opera singer named Amelita Galli-Curci that developed a goiter, or a really big thyroid. And I think this was in Chicago, mid 1900s.
Sure.
She kind of waited because everybody knows about recurrent laryngeal nerve injury, and she really didn't want this out because she didn't want to risk a nerve injury. So she ended up eventually getting her thyroid out awake. Just under local. Mm-hmm. And her recurrent nerve was fine, but she had an EBSLN injury during that surgery, and it changed the tone and timbre of her voice. So in addition to that recurrent nerve, we're always careful with the EBSLN, especially in people that use their voice for a living, because it can be a significant trouble.
There might be some people that would know me that'd be like, go ahead and clip that.
I think that's a pretty common statement between husband and wife. They're like, that's fine.
Just go ahead and cut that. You're good.
Yeah.
Dang it, my joke. All right, it's already been done. Okay. Are there? What are some of the? How long have you been doing this type of surgery?
So I did this in training.
Okay.
And that was kind of where this interest developed, right?
Yeah.
And when I came out here and started practicing, I've built a endocrine surgery program in Spearfish. So I've been there for 6 years now, and I've been doing it the whole time. So
has there been enough technological change since the time you started till now that you've been like, wow, all right, here we go? Or is it pretty? So I love medical quotes. They're like some of my favorite axioms, right? And one of them is that
the best localization study that you can get is to locate a good parathyroid surgeon, right? And so you have all of these things, all these little tools and tricks that can help and can make you better at this. But the best thing that you can do is just to practice at it and to be good at it.
Okay.
And so, there's new technology out. There's all these new things. But, when the rubber meets the road, you're really just a surgeon looking for a parathyroid.
Right.
So...
I see that Dr. John Palmer has just arrived here.
Yeah.
So what we'll do is we'll get him set up, and then we'll add him into this conversation if that works for you, Doctor.
Yeah, absolutely.
And joining us now is Dr. John Palmer, who is a doctor of osteopathic medicine in Spearfish, specializing in endocrinology. I'm glad you could join us, Doctor. We've been talking, Dr. Badger and I, about the parathyroid and the surgery and the art, as it were, as Dr. Badger said.
The hunt for the parathyroid.
The hunt, yeah, exactly. Dr. Palmer, what's your background in this profession, and why did you choose something like this?
Well, absolutely. So, John Palmer, endocrinologist here with Monument Health, and not only Spearfish, but Rapid City, Lead, Deadwood, Belfouche.
Everywhere.
Yeah. We go
You're
everywhere.
Western South Dakota.
Western South Dakota, one-stop shopping for endocrinology. I went into endocrinology just mainly because of the diabetes aspect of things. That's what really drew me into endocrinology. But as part of that, it's a very diverse background, too, as far as what we do. We take care of thyroid. We take care of parathyroid, which we're obviously talking about today. Take care of adrenal disorders, pituitary disorders, the whole gamut of things. So it really is a vast array of things that we do, and there's no day that's the same, that's for certain. As it pertains to parathyroid disease, that's a very common thing, that we see, and it is, to Wes's point, the hunt for the parathyroid. Sometimes I like to refer to it as "Where's Waldo?" because Waldo is hiding, and it's a tricky thing, and a lot of times they're straightforward slam dunk cases, and other times Wes and I put our heads together and go, gosh, is this really the right thing to do for the person? Just because it's a little tricky as far as, is this the appropriate patient to send? Are we going to have good results that we all want to have? And it ends up being sometimes a lot of work.
So how do you two work together then? What's your roles together in this?
No, that's a great question. So, it's collaborative oftentimes between myself and surgery and also primary care. And oftentimes it starts at the primary care level where the patient's primary care provider will notice that their calcium levels are high. Oftentimes it may just be on a random blood test. The blood test will come back and the calcium levels are elevated, and then they send them to us to try to work up, why that calcium might be high. And you can have calcium issues that are associated with parathyroid disease, or you can also have calcium issues that can be related to other things such as cancers and other rare disorders like sarcoidosis and a whole bunch of different things. So the endocrinologist's role is to try to hammer out the diagnosis and to say, all right, is this primary hyperparathyroidism, meaning one of those 4 parathyroid glands is misbehaving and causing problems, or is it something else where we need to figure out what the cause is? So we go through that workup through blood tests and urinary tests, and we'll establish the diagnosis that, yes, it does appear that one of your 4 parathyroid glands or more is misbehaving, and we need to go forward with additional workup. From that point in time, then we'll start the imaging studies. We'll get what we call parathyroid scans, a nuclear medicine study to see if we can localize which of those 4 glands is causing trouble. Sometimes we'll do ultrasounds. Sometimes we'll do CT scans. A lot of times we do all 3 of them because they can be kind of bothersome and not really want to declare themselves.
Now, is that nuclear medicine, that aspect of it, is that relatively new for you guys, or has that been around a while?
Sesame-Be's been around a long time.
Has it really?
Yeah. It's kind of like one of the original parathyroid localization
Really?
studies. Yeah.
My whole career, we've had them. Yeah. I would say the newer imaging that's probably been the best has been the 4D CT scan. That's been a lot more, I think, sensitive to try to localize these.
Now, we were talking about the other issues with the parathyroid, but of course the big question that everybody asks or wants to know is when that can turn cancerous, and then what's happening.
Yeah.
Is cancer common in the thyroid?
So those are kind of 2 different questions, right?
Okay,
so,
yes.
Thyroid cancer is incredibly common. Parathyroid cancers are incredibly rare.
Really? Okay.
And they, that's always a question patients ask when they come in and see me is like, what's the risk this is a cancer when you take it out? And those look a lot different than people that just come in with primary hyperparathyroidism. That's not a subtle thing. It's usually a diagnosis that you don't get surprised with, and it's treated pretty significantly differently than a standard parathyroid.
Really?
Treated. Yep.
So thyroid cancer is pretty common. Why is that? Is there? Do you guys have a reason? Is there?
So
why
there's a
it would be?
lot of explanations. I think, in my opinion, and having done this between fellowship and practice 18 years now, I think the reason that we see maybe more today than maybe we did at the beginning of 18 years ago is we're just doing more imaging modalities. We're doing a lot more
Really?
screening.
Yep.
Carotid ultrasounds looking for vascular disease. We're doing more MRIs, CT scans. I would say the vast majority of thyroid cancers that we diagnose are found incidentally, meaning we were looking for something else and they say, you also may need to get that looked at as well. Turns out it's thyroid cancer.
Yeah, absolutely.
So what does it feel like then? I mean, do you know? Can you know if you have thyroid cancer?
Yeah, I have great respect for people that get sent to me from PCPs and the PCP has felt their nodule because I am terrible at feeling
Oh,
nodules.
really? So it's
100%.
something. It's something you can feel.
Yeah, so
Sometimes.
if they get big enough, you certainly can. I don't feel them that well. I feel them with ultrasound pretty good.
Right.
Yeah, we used to joke we let the physical diagnosis confirm what we already know on the imaging studies.
Yeah.
So,
Yep.
So how does a term that a lot of people know too is hyperthyroidism, right? What is that?
So hyperthyroidism just refers to the thyroid's overactive.
Okay.
And so the thyroid is physically making too much thyroid hormone. The thyroid kind of has its hands in a lot of different things, whether it be the cardiovascular system, the nervous system, the digestive system. So patients typically that have hyperthyroidism are going to come complaining of maybe unintentional weight loss. They might feel more anxious. They might have insomnia. If it gets severe, you could even see a significant tremor. And I've even seen patients where, from a psychological standpoint, it also impairs judgment and thinking to the standpoint of very, very hyperthyroid parameters.
Can pieces of the thyroid be removed without taking the whole thing?
So I tell people there's two thyroid operations. Either I take out half of it or I take out the whole thing. Taking out nodules, kind of like enucleating it from the surrounding tissue, isn't really a great operation to do, probably because you're going to leave a piece of whatever you're trying to get out. And so either a lobe, meaning half the thyroid is coming out, or the whole thing's coming out.
Okay. After what's recovery like after a surgery like this?
So it kind of depends. So parathyroid surgery, if we do like a minimally invasive surgery like we talked about, we find that little gland, pop it out. In 30 minutes, people go to recovery, and they go home that same day.
It's that quick?
Yep.
It can be that fast?
It's usually pretty straightforward.
Okay.
If we go to the operating room and we're hunting for 3 hours and looking in all the spots, that's kind of a lot of surgery to send somebody home with, and I typically keep them overnight.
Mm-hmm.
For thyroid surgery, if I take out half the thyroid, I send them home the same day too, kind of very similar recovery. There's some things that kind of go along with taking out the whole thyroid that add a level of risk, and I keep those people overnight just to observe them and make sure they're going to do okay.
What happens if your whole thyroid has to come out? What's it like for the rest of your life if you don't have that in there?
Mm-hmm.
Well, so from that standpoint, then you need thyroid replacement. And I like to talk with patients about that before their surgery. There's a lot of things that are on the internet, like many things that may be not fully truthful.
Of course.
And there's a lot of urban legends, a lot of myth, a lot of half-truths, no truths, and complete lies on the internet as it pertains to thyroid. So I like to go over those things, fairly frequently with patients before even the time of surgery. So if I'm going to send someone to Wes who, we're pretty certain has thyroid cancer and they're going to get the entirety of their thyroid gland out, part of that conversation is you're going to need to be on thyroid replacement. But then the good news I say with that is that's one of the easiest things to do in medicine. Because if you look at levothyroxine or the synthetic version of thyroid hormone that we use, it is essentially the same molecule that is being made naturally by the thyroid gland. And I'll tell patients all the time, the only side effect to this medication is if we give you too much or too little. But we're in essence tricking your body into thinking that the thyroid is functioning back online as it should. We follow your laboratory studies to make sure that they're perfectly normal. And if anything, particularly if it's a thyroid cancer patient, we'll even err on the side of maybe giving you just a little bit more thyroid maybe than you need, because studies have shown that maybe there's a less chance of recurrence when we do a treat in that sort of fashion. So I like to get out in front of maybe some of the fallacies that are out there online as it pertains to thyroid replacement.
Is it just a pill?
Just a pill, once a day medication.
Yep.
Okay. Now you're speaking of the myths and getting ahead of some of this misinformation. As doctors, do you just sometimes go home at night and bang your head against a wall because of what TikTok has put out I mean, does it get frustrating?
From a surgery standpoint, one of the most fascinating things that I found about surgery is that, people that trust me to do surgery are less likely to trust me when I tell them they don't need surgery. Like, people come to see me and I'm like, I don't think you need surgery for this, or probably not something that we should do.
Yeah.
And that's a harder pill to swallow than like my risk benefit discussion about surgery.
Yeah.
And that's always a little bit frustrating, because quite frankly, I make my living doing surgery.
Right.
And every surgeon wants to operate. And if you come in to see a surgeon and they're honest with you and they tell you, I don't think this is a surgery problem that I'm going to fix, you've probably found somebody that's hopefully honest with you.
Right, exactly.
Right?
Yeah.
So that's one of my big frustrations, I think, within surgery.
What thyroid myths drive you crazy, Dr. Palmer?
Well, there's a lot of different things that are on the internet, of course,
of course.
And all patients want to do is feel better.
Yes.
And I totally understand the thirst and want and desire to obtain more information, because they truly want what's best for them. I truly want what's best for them. A lot of times that message gets blunted and blurred when you get this information from the internet and from sources, that may not necessarily be from the standpoint of the background of knowledge or acumen with the management of it. And then there's some things that are just, frankly, I think business opportunities where maybe patients are getting taken advantage of. And that's what we run up against a lot. What I try to do with patients is just let them know they have options, and we do get a lot of patients who will have thyroid surgery. We will get them on the typical regimen for thyroid replacement. Their numbers look perfect, and they still feel poorly. And so these are the conversations I have with them. And that medicine is both art and science. From the science standpoint of things, you look perfect. I say, get out of my office. You're great, but you're not perfect. You're not feeling well. What are other things then that we can do? That's where we try to meet our patients in the middle. Are there other formulations of thyroid that are out there, little non-traditional things? I'm completely fine with those things, so long as two things are being accounted for. One is, are your levels appropriate where they should be, and two, are you feeling well? And if I can achieve those two things, I'm going to be happy. Whether that's with traditional thyroid replacement with the levothyroxine or Synthroid, or whether it's alternative forms of thyroid. Sometimes we'll use what we call desiccated bovine and porcine thyroid hormone coming from pigs and cows. I don't care what you're on, so long as you're happy with how you feel and your labs are being appropriately treated. And so that's just kind of the art of medicine, on top of the science of just trying to meet the patients where they're at.
Well, I asked Dr. Badger when we started what his favorite type of surgery was, and he mentioned that this type of parathyroid or thyroid surgery. So
I'd like to give you the caveat that the easy ones are like my favorites.
Like the ones I send him sometimes, he's like, dude, what is the hard one?
A straightforward parathyroid that's like glowing on a localization study, I feel like I should pay people to let me do that. That's a lot of fun. But when I have to go hunt for 3 hours,
I totally
question why I do it.
Right.
Yeah.
And that's the good thing about working with a guy with Wes is we will have conversations. I'll send him people that he won't operate on. He's like, I just don't know, and we're in agreement that it's there, but we come to the conclusion like this may not be in the best interest for this individual, and that's the good part of having collaboration, with the surgeon you trust.
Yeah, absolutely. I mean, you two guys seem like you work really well together. And, it's nice having guys like you in our community, from Spearfish to Rapid City to Western South Dakota, Dr. Palmer. You're our traveling doctor, I guess, for sure. I want to thank both of you guys for coming in and talking about this. This has been a lot of fun and super interesting. I learned that there was a thyroid behind the thyroid. So, I'm going to go home with some new knowledge tonight for sure.
See if you can feel it.
Yeah, right. Dr. Wesley Badger and Dr. John Palmer, thank you both for coming in and talking. I appreciate it.